It's 7:15 a.m. on a Monday, and a very specific chaos is taking over the house. A child sits on the edge of their bed, gripping their stomach or even vomiting as the clock ticks closer to the school bus's arrival. Parents watching this happen face an agonizing choice. You either force a child who appears genuinely ill out the front door, or you yield, let them back into bed, and call the school attendance office. Most parents eventually choose the latter. But then an unsettling illusion occurs. By noon, the stomachache is gone. The tears stop. The child seems perfectly fine, leading parents to suspect they are being manipulated by a sudden bout of defiance. The child is not faking. The rapid recovery at home actually proves the opposite. The child's body is producing a highly specific biological fight-or-flight panic response that is triggered entirely by the threat of the school environment. Because this results in missed classes, schools and parents often classify the behavior as standard truancy. This comparison chart shows why that classification is dangerous. Truancy typically involves a student concealing their absence, exhibiting low distress, and sometimes engaging in antisocial behavior. School refusal happens out in the open, with complete parental knowledge, and is driven by intense emotional panic. Responding to a biological panic attack with detention slips or punitive threats completely misses the underlying threat. It alienates the student and isolates the family in a dangerous vacuum of care. To understand why this behavior escalates so quickly, we have to look at the psychological mechanism driving it, the negative reinforcement cycle, where avoiding a scary situation temporarily reduces fear, making the urge to avoid it even stronger the next time. This flowchart maps the mechanics of the avoidance spiral. When the parent allows the child to stay home, the child's brain registers massive chemical relief from the panic. That rush of relief actively rewards and reinforces the avoidance behavior. The relief is strictly temporary. By Sunday evening, anticipatory dread kicks in, rebooting the cycle so physical symptoms are noticeably stronger by Monday morning. With every revolution, the phobia tightens its grip. The brain learns staying home is the only way to survive, making eventual return exponentially harder. At any given time, 1 to 5% of school-age children are caught in this loop. The initial panic is usually sparked by major school transitions, returning from a long break, or the stress of an undiagnosed learning difference. The clinical threshold for intervention is strict. If a child hits 2 weeks of chronic absenteeism paired with physical symptoms that magically resolve on the weekends, the situation is critical. Letting the avoidance continue fractures a child's academic trajectory. Data shows that untreated school refusal in childhood strongly predicts adult anxiety disorders, clinical depression, and significantly lower overall educational attainment. This is the central tragedy of the loop. A parent's natural empathy, their immediate instinct to comfort a crying, sick child, is the exact mechanism that accidentally traps them in a worsening psychological crisis. Escaping the spiral requires parents to act against their protective instincts. It requires a structured clinical intervention designed to tolerate the morning distress without giving into it. The frontline approach is cognitive behavioral therapy combined with graduated exposure, a method that slowly reintroduces the child to the school environment in manageable, calculated steps. This node diagram illustrates the necessary triangle of support. The child must learn distress tolerance skills. The parents must learn how to validate their child's feelings without accommodating the avoidance, and the school must execute structured partial day reentry plans. When this clinical protocol is followed, the success rate is high. Most children successfully return to their normal school schedule within 2 to 8 weeks of starting evidence-based care. The duration of the avoidance directly dictates the length of the recovery. Catching the behavior early and applying immediate intervention is the single most important factor in a child's success. To execute this intervention effectively in Georgia, families and districts utilize MentalSpace School, a dedicated K-12 mental health support system built precisely for this crisis. Traditional therapy often involves months-long waiting lists, allowing the avoidance spiral to deepen. MentalSpace removes that friction entirely by offering same-day teletherapy assessments, meaning active intervention can begin within the same week a parent asks for help. They also possess a structural advantage. MentalSpace therapy teams coordinate directly with local school administrators, counselors, and nurses to build, monitor, and adjust the child's graduated reentry plan on the ground. The platform is designed for broad financial access, offering a $0 copay for Medicaid patients and accepting all major commercial insurance plans, including BCBS, Cigna, and Aetna. A child experiencing school refusal is trapped in a terrifying physiological loop. But with early action, specialized therapy, and a coordinated plan between the home and the classroom, that cycle can be permanently broken.